All right, good evening, everybody. I'd like to call the August 14th Program and Budget Committee to order, and I will read our mission statement. Macomb County Community Mental Health, guided by the values, strengths, and informed choices of the people we serve, provides quality services which promote recovery, community participation, self-sufficiency, and independence. With that, we'll move on to the adoption of the agenda. I'll take a motion to approve the agenda. Motion from Chris, support from Lori. Any questions or comments on the agenda? All right, seeing none, all in favor signify by saying aye. Aye. All opposed? The agenda is adopted. Next item is hearing of the public. Anybody from the public wishing to speak, you have 5 minutes. Anybody from the public? I was going to read the rest of my notes here, but if nobody's here from the public. All right, we will close the hearing of the public. Next is item 5A, request to approve a request for information RFI for crisis phone line services and centralized telephonic access. I'll take a motion to approve to move to full board. Motion from Kathy. Support from Ryan. Dave, did you want to speak to this?
Good evening. Just briefly, I requested this RFI. We're currently looking at access in general to our community mental health system. Met with Adam and I had a meeting last week, and I'm learning more about what we have available, how we used to do things, but I want to see what's available out in the community. So the first part of that would be a centralized telephone access number. They would do some initial triage, screening, direct people through the focus calendar. When they were appropriate for our services, they would end up with an intake appointment, date and time. It helps hit all of the performance indicators that we're required to track and to hit at a 95% mark at the state level, and it would just streamline some things. We may or may not be able to do that one internally, and I'm looking for some comparisons. The second part is the crisis phone line. That's the phone number you call when you're in crisis. The suicide prevention. What we're looking at there is, again, what's available to our community as far as comprehensive 24/7 degreed professionals handling those calls, and then what kind of data and feedback could we get into our system. So I'm really just curious, and I want to see what's available to our community and compare it to what we're able to do internally and make our decisions going forward.
Any questions? I don't see any. All right, seeing none, we have a motion and support. All in favor signify by saying aye. Aye. All opposed? Motion passes. Next is item 5B, request to approve a request to add provision of intensive crisis stabilization services to New Oakland Child and Family Center's contract effective August 1st, 2019 through November 1st, 2019. I'll take a motion to approve for full board. Motion from Chris, support from Lori. Dave, did you want to talk on this one?
Again, what we're looking to do is expand our the mobile crisis screening face-to-face. Well, face-to-face is what the New Oakland calls their program as well. The intensive crisis stabilization is one of there's about half a dozen services that require the approval from the state of Michigan for that provider to report those services. New Oakland has been approved and is doing this in other counties. I was working with them in Wayne County. What they allow us to do now is pretty much be a one-stop shop for the mobile crisis screening. So they'll go out to a family home, a residential group home, to an emergency department, do the clinical screen. If the person can be diverted, they can bill and report that as intensive crisis stabilization follow that person according to those guidelines, which are very rigid. It's one of the better defined services in the Medicaid manual. You have to have a doctor associated with that team. They have peers. And what happens in some cases is we can have a psychiatrist talk to the emergency room physician. Over time, what we see is the emergency room staff become familiar with our crisis team staff, and that trust builds, and then we see those diversion rates go up appropriately. And then, like I was saying, they can follow the individual into the community, make sure that they're connected to the outpatient provider. New Oakland also has a partial hospitalization program. We will make sure that that they're not referring people that they see in crisis directly to their partial program. Those requests will go through our access center for prior approval, so there's no, that they're not referring to their own programs. So just by adding this code to their contract, we can get those services up and running quickly, which are needed in our county.
Any questions or comments on this item? All right, seeing none, all in favor signify by saying aye. Aye. All opposed? Motion passes. Next is item 5C, a request to approve a request for proposal for language interpreter services via video remote interpreting. I'll take a motion to approve for full board. Motion from Megan, support from Linda. Dave?
Again, this one is my request. Was working with a specific company before, and the way the video remote interpreting works is it's a backup or a safety net for those urgent situations. We have cases now where people need an interpreter. We make those arrangements. The interpreter shows up, but the person doesn't. We still end up paying for those interpretation services, and it's about $75 an hour. With the video, you're only paying for exactly the minutes that you need. They're very flexible. These are typically very highly accredited interpreters in the medical field. They can handle multiple situations, like somebody who speaks Arabic and is deaf. They can actually do a split screen and have the language interpreter on the same screen as the sign language interpreter. So they help us increase the cultural competency and meeting the language needs of the people of Macomb County. We just want to see what else is available in the community. We currently have a provider for interpretation, but we're not using their video remote interpreting services, and I think we can get a good price for us and the providers in Macomb County.
Any questions or comments? Kathy?
I'm looking for my request thing. I can't find it. So I think you answered my question, what I was thinking, in that they do have the certification for behavioral health and medical health? Medical?
We'll put it in here.
For behavioral as well, or medical, you mean? Is there a difference? I don't
There's
know.
no behavioral health certification for interpreting that I'm aware of.
Oh,
There is a one for medical.
There is for medical, right.
But we'll see what's available when we put the RFP up.
Great, all right. So we currently have a live company then? Live, for lack of better description, they would actually show up at the appointments? Okay, thank you.
Thank you. Any other questions or comments? All right, seeing none, all in favor signify by saying aye. Aye. All opposed? Motion passes. Next is item 5D, recommendation to award Macosa contracts for outpatient adolescent residential treatment and recovery housing resulting from a supplemental request for proposals. I'll take a motion to approve to full board. Motion from Brian. Support from Linda. Go ahead, Randy.
Well, I was hoping Dave could do my presentation. He seems to be on a roll. I'm sorry for the long title on this. I don't know what got into me, but normally I would just say, award contracts via the RFP. But Basically, it describes everything that we were looking for. We wanted to have get some more contracts for outpatient, adolescent residential, and detoxification services and recovery homes, all of which we had determined that there was a need just based on the kind of service flow that we were getting and that sort of thing. The usual practice, we had, it's wide open bidding, and we ended up with about 10 different programs that bid. The most came out of the recovery homes. We came out, bottom line is we came out with 3 different recommendations, one for each service. We have the Catholic Charities of Southeastern Michigan for outpatient treatment. We have Grace Recovery Center for recovery homes. And we also have Great Lakes Adolescent Recovery Center. The process, do you need me to go through the process? It's pretty well laid out there. Well, okay, if you don't, I won't bore you with the details on that. All of these, we did, after we did initial scoring, after we did the initial scoring, we decided based on criteria which ones we would want to contract with, and then these were all new providers, which is what our intent was. So then we would choose from that which ones we would bring forward. We visited all of the facilities for all of the programs except for Great Lakes Adolescent, which is up in the UP. So we ended up with 3 recovery homes that were possibilities. We went out and visited the homes, and they pretty much eliminated themselves when you saw the conditions of the homes, the kind of stuff that was sitting in their basements. They weren't really up to code. So we eliminated 2 of them. Grace Recovery House is very clean. It's new. They just started providing services this year. So the woman that runs it has over 20 years of in recovery. She has very clean. They've adopted all the right right policies and procedures within there. We feel very confident that there'll be a good one. And they offer 6 beds for a women's home, and we need to have more women's homes in the recovery areas. So, as far as the Holy Cross, or I'm sorry, not Holy Cross, but Great Lakes Recovery. It's kind of right now we're bringing that forth as having another option for us, even though it's way up in the UP. We have a contract with Holy Cross, which is up in the Saginaw area. They have gone through major restructuring this year. They've dropped providing adolescent detox, and they've also and a lot of staff are missing. So that's why we decided that we needed to find another place, so we need another option. I don't know, we don't have as much confidence in that facility as we did before, but having a secondary one is helpful. Would have been nicer if it had been closer. What we'll probably be asking to do is to have us negotiate with another more localized adolescent residential facility. We've done that before when we don't get what we want. I don't know, is there anything else? Any questions that you might have of me?
We've got a couple of questions, Randy. Linda.
It's not, I don't know which one this applies to, but I ran into a young man who is in recovery, and he recently went to he said it's brand new and it's so nice and all of that, but for methadone, we didn't previously have that. And so do we have just 1 bed, or?
Oh,
he's on methadone, so he couldn't go to the other recovery
Yeah, we've
houses.
had, one of the issues that we've had with recovery homes is they don't want to take people that are on methadone, Vivitrol, or Suboxone if they're on any kind of medications. We've had Eastland, the Eastland House has been doing that. They've been the one facility that hasn't, and they have 2 facilities. So we, you may recall that when we got our most recent SOAR dollars, the state opioid response dollars, they provided some dollars to pay for recovery homes for medication-assisted treatment. So that's probably Sacred Heart. Sacred Heart, we contracted with them, which was a nice fit because Sacred Heart, that finishes their continuum of care. And now we've got a facility we can trust for that.
So it's nice to hear from someone in the community who's actually using the service, and he just raved about the people who worked there and the job opportunities and the support that he was getting. and
Send
that
them
it
my
was
way,
good.
would you? We don't hear enough of those.
Okay, I'll give him your number, Randy.
Yeah, okay.
Ryan?
All right.
Hi, Randy. Did you say that you visited all of the facilities other than the one located in the UP?
Yes.
Okay.
Now, with the UP, what we did do is they contract with 3 or 4 PIHPs up in the northern region. So we contacted each of them, and we converse back and forth, and asked them what kind of. Their proposals were stellar, and in addition to that, we asked them how they were as a provider, and they got very, very good reviews. So normally we would go. But to be able to take that drive up there in the middle of a lot of the other things that we're doing, and we're visiting all these, we just decided not to do that. But
Sure. But every other place you visited?
yes,
Okay.
every other one.
Good.
Thank you. Any other questions or comments? Dana?
Hi, Randy. I just have a couple of questions. So for the UP one, is there anything that prohibits you from contracting with somebody out of county, or that's not an issue?
No. In fact, about 50% of our residential programs that we contract with are out of county. A lot
Good
closer.
to know these things.
Yeah. Oh, yeah.
And then, and how does that work? Do you provide do you recommend they go there and provide transportation? Do they have to get themselves there?
From what I understand, we have to get them to the bridge.
Okay.
And then they will pick them up at the bridge. So, but that means you're going to have 6 hours of driving and it will be the parents that will do that. We haven't really worked out all that. There might be a way that we could do, but that's typically how the other PIHPs do it.
Okay, I just wondered.
Yeah, no, it's a good question.
So do we have to pay the fee to go over the bridge, or do they? I'm just kidding. I'm just kidding. Nick, go ahead.
Randy, can you tell me again what these acronyms mean on the charge? OP total and IOP total, number one. And number two, I just don't know what the
Oh,
acronyms are.
okay. The OP and IOP, that's outpatient and intensive outpatient.
Okay. And at the risk of being excommunicated, can you tell me why Catholic Charities has an NA on the?
They chose not to.
They don't provide that?
They don't at this time. But typically what happens is people start off in outpatient, and after we contract with them for a while, they'll run across clients that need to have more intensive services, and that's when we start contracting with them. So that's fine. We're fine with that. The IOP piece,
Or you can send them somewhere else?
yeah. Yes, we
If they
can.
need intensive, then that's in the rest of the budget.
Yeah, we have several providers that do IOP. All of our, except for them right now, all of them offer IOP services.
Okay.
Any other questions or comments on this one? All right, seeing none, all in favor signify by saying aye. Aye. All opposed? Motion passes. Next is item 5E, recommendation to accept opioid health home award from Office of Recovery Oriented Systems of Care. I'll take a motion to approve to full board from Nick, support from Linda. Randy, go ahead.
Okay. We essentially received, we were approached by the Office of Recovery Oriented System of Care at MD-DHS, that's our primary funder, for us to establish an opioid health home, which is not a physical home, but it's a model that is established for coordinating services. We were selected because we're one of the highest, one of the areas with the most severe problems related to opioid abuse in the state. What they're offering us is $3.2 million to be spent between October of this year until September 30th next year of the SOAR dollars, state opioid response dollars, supplemental, to establish this model of care. This model is very much kind of it's a coordinated system of care. It combines the use of our current system for, we're using the term for this purposes. When you think MAT, we've talked about MAT before, medication-assisted treatment. That's our methadone programs, Vivitrol, Suboxone, those things. We use it and those are provided at opioid treatment programs, the OTP, which is what's referred to in this document. And then there's also, and that's they're part of our network, and they're seeing our clients, our traditional clients for Medicaid, those that might be block grant, HMP, and all of those. There's also a group of providers out there that are not part of our system. They're typically run by physicians, and they're called office-based treatment programs. And it's the same thing with they serve opioid clients and provide MAT services with them, but they do it outside of our system. And whether or not it's not coordinated, and there's quite a few of them out there. We got a list. There's about 40 or 45 people just from a preliminary list that we found right here in Macomb County of the office-based, the OBT, and. And what's the part of the problem that you get with that is that that group, they're outside of our system, they're not providing SUD treatment services as part of that. So those people are just getting the meds and whatever, the medical kinds of minimal amount of medical services. And so we don't have anything to do with them. We don't know who they are, any of that sort of thing. So what this does is they talk about a hub and spoke model. We would be the hub. We're the ones that would be centralized, that would coordinate the services along with both of those groups. They have to be the people that we would serve are people that have to be on Medicaid or HMP. And they also, but they're supposed to have a secondary health problem, which can be alcoholism or cocaine addiction or something like that. So this model allows us to really bring those more into fold. We look at, so besides that, we also have FQHCs out there, the Federal Quality Health Centers, to which we have very little contact with as well. And we'd be looking at trying to hook up with them, bring them into our system, not as we know it, but it would be a different kind of a system, but which we have to learn how that all works, because we're still very much in the beginning discussion stages on that. But that would have, so we would start with those and try and get them, because what we're trying to do is we're trying to get increased medical, really the more holistic kind of a model that we have with them, taking sure behavioral health needs, making sure that the medical is being done, and all the the other things that all the other needs that are being met. It's kind of exciting because there's a lot of opportunities that this presents for us. A lot of challenges as we start up, but I think it's got a lot of real possibilities with it. And you can't snub $3.5 million. I mean, the state is there to give us the financial support. They're there to give us the structural support. They're there for us. I talked to it's been done one other place with the state for opioid. It's been done in a couple places in Michigan just for mental health. But it's only been done one other place, and the place they chose for the first one was up in Region 2, which is the tip of the lower part of the tip of the lower peninsula. Yeah, I know how that works. It's like right here. Yeah, and they identified them as being the most severe problem. I asked them, so I've gotten kind of at least a brief sharing of experience that they've had, because they've been doing it for about a year and a half now, and they're just now getting it up to full speed. But they're saying that, I asked, what kind of problems we're going to encounter, and what they thought the gains were from it, and they think that for them, they have it's a much smaller system, and they didn't have any one treatment. They didn't have one. They only had one methadone MAT program in that area. Now they have like 7 or 8. So, and they cover a broad geographical area, but not so much in the numbers. But they're saying that that they have thought that in the year and a half that they've done, they've had a lot of success. They believe that their clients are getting much better treatment now, that it's coordinated, it's coordinated. The medical care is better, and they're getting more access to services than they did before. And what we want to see, I think one of the big things that we would want to see is that we need to have more people out there that are engaging into MAT services, because that's the science that increases people being in treatment longer, getting into longer-term recovery. And we've got it in place, but people aren't coming just yet. So we're doing some things to make that change, but this is one of the benefits from being there. So I'll stop there and see if there's any questions.
Thanks, Randy. We have a couple. Kathy?
Thank you, Randy, for going out for this. Well, I have a couple questions. How do we measure success, or what is the grantor looking for in terms of success?
I think we're still defining it. I think one of the things that we talk about, what we're looking at is we want to make sure that more people are engaging with physicians, that more people are coming and staying into treatment. And I think more engagement by the OTBs, or the office-based ones, the ones that are part of our system, into our system, and making sure that clients are getting treatment into our system and or are providing them themselves. Those areas are, I think that's it. The actual measurements, I think we have to define better, in terms of what percentage we're talking about. When I talked to Region 2, they didn't quite have the data out there yet. They had what their perceptions were of those that are participating in the group. So,
okay, but do we have to meet certain requirements to be able to get this again, to renew it for the following year?
Well, yeah, but the state's very flexible on this because they want it to occur, and I think they're still looking. If you looked at Region 2, that was their big pilot, but it was a pilot for a rural area. And I think what they're looking at with us is we're more of a suburban, urban kind of an area, and they want to see how well it will work in that area. So, and we've had probably 5 or 6 phone sessions in the last couple of months. Mm-hmm. And it's very clear that they're very supportive of that. And I asked Region 2, and they said the state's been great for this whole thing. So.
And do we have the ability with our software and with our client services record keeping?
I think there's going to have to be some development there, because that's a big part of it when you're looking at when you look at the health records. The capacity's there, but I don't know that it's there, and it's got to be able to hook up with the other folks that are coming in, the other spokes that are coming in, I guess.
All right, so that'll be part of how that money will be used then to develop.
Yeah, the money's going to be one time, 3.5 million, and that's a max. But if we end up, for some reason, we need it more and we're getting it more, we can always ask for more. And by this time next year, they'll be doing no-cost extensions probably for the money they haven't spent, so we can probably ask for it. But the whole goal is to do the initial work up front, get the structure in place, get the work, get it up and running, and then Medicaid itself will take over. That Medicaid will be paying for it then, because it's still that kind of a model. So it's kind of like, when you start up a new program and you have startup costs, mm-hmm. That's what this is going to be. The 3.5 million is for startup costs.
Okay. So now I'm asking as a not county, but just as a resident of the state of Michigan, are there measures of success for this?
Yeah, there are some. But I have to, I can't tell you what they are right now.
Okay, but all right, it's a lot of money, and I would just make sure.
Yeah, it
wanna
is a
make
lot of
sure,
money,
and
yeah.
if, sounds like this, the MOT, is that? did I get
MAT,
the-
yeah.
Oh, MAT.
Yeah.
Sounds like that's been shown to be a successful
It has been very
model.
successful,
So-
especially since they got away from just methadone, because methadone is still considered to be the single most evidence-based practice for dealing with opioid addiction.
Mm-hmm.
And then since Vivitrol is very successful for getting people when they first come into treatment. You know, it's really for when people come into treatment, it really reduces the withdrawal symptoms. It can block, if they try to use, it can block the effects of that, so they're not getting that positive reward from using it, that sort of thing.
All right, thank you.
You're
Thank you,
welcome.
Mr. Chair.
Thank you. Linda?
Great, Randy, that bringing more money to the county. Just a couple of things. So generally, the state funds only evidence-based things. Would this fall under that category where they've already?
Yeah, that's the emphasis. In fact, the feds require that now too. So,
Are you shifting your whole system under this grant, or just a pilot, or just?
no, this will be kind of adjacent to our current system. So they'll have, our providers, the methadone, the MAT providers will still be providing the same services as they are right now, but they'll be taking on an additional population that will come in under the model.
And then, has this already been approved by your board?
Yeah, the Oversight Policy Board did approve that, which they did on the RFPs, by the way. I was supposed to say that, but I didn't. I'm sorry.
And then, did you, you don't have to answer this, Randy, but did you talk to some of our providers like Karen Sacred Heart and so forth about what this, how this? might-
No, actually, I mean, I think where we started was our conversation with the state. The state's interested. The reason we're coming to you now before we've done that is because the state wants to know whether or not we're interested in doing it. Because if we're not interested in doing it, they're going to go somewhere else. So we have not pursued, besides our providers are so under the water right now with all the other initiatives that they have going. But if you were to approve it at the next board meeting, then we'll start that conversation. We'll start with the Sacred Hearts, Quality Behavioral Services, Meridian Health, and Biomed. Those are the four that we have.
Just one other quick thing, I don't really have enough information about this to even start to analyze it. It does kind of, just kind of trigger something about a red flag, I guess that's what the thing is. But, when it combines the medical, the physical and the behavioral health, does this put it in a neat package for someone to take it all from us? That could then even be a thing.
I don't know. Just about anything you do out there could do that now. I mean, if the state were to decide they were going to go in a certain direction, they could take anything that we have established out there and say, well, we're going to do that. I think it's unlikely. It's not, opioid health homes have been around for a few years. I think about the same time, and probably before that, Affordable Care Act came into play, which was 2014. So they've been in, and they typically have started, I think, in hospital-based programs. That's where the home, I think, idea came. And now this is more on an outpatient base. But I don't think I wouldn't be concerned. I think it's unlikely to do that. But
Any other questions or comments? I don't have anybody else on my list. All right, seeing none, all in favor signify by saying aye. Aye. All opposed? Motion passes. Thank you,
Thank you.
Randy. Nice job.
we'll keep you apprised.
Thank you. Next up is item 5F, engagement letter for consulting services, Raymond. I'll take a motion to approve to full board. Motion from Kathy. Support from Linda. Turn it over to Dave.
This recommendation came out of the Authority Task Force pretty much we had reached a point in the task force of exploring the pros and cons of continuing the way we are now or becoming a mental health authority. It was really time to start getting down into the details. So we were discussing consultants to that group. The financial side plays a big part in that process. I was familiar, when I reached out for subject matter experts, some of the people that were recommended to me, Richard has actually consulted with them through their process. He's currently associated or affiliated with a half a dozen various PIHPs and regions. He's gone through, helped them transition through the process. So we were thinking he would be a good subject matter expert to work with our task force group. With that task force, we've identified areas that we'd like him to work with and address. The initial proposal had a higher rate. It had more than one rate, and he agreed to give us the lower rate, but it was kind of fuzzy, so he cleaned it up. So what you see in front of you is he's the principal discounted rate. It would be 1 day of service on site, 8 hours, guaranteed, and we would be working to maximize his time spent with us. That's about it.
Nick?
As the board knows, I've opposed this concept for some time for several reasons, and I won't bore you on all of them except to recap them very simply as the fact that Macomb is unique, that we have had experiences transferring from authority to agency and agency to authority in other departments within the county, and I think that's much more instructive because of the unique nature of the county, and that a couple of us, Dave included, have had experience with these transitions that I think we needn't expend this relatively large sum of money, and it isn't a huge sum if we limit it to the $3,000 per month, which is not exactly what the proposal says. It says that's one option, or we may go well beyond that. I'm continue to be concerned, and I sent you a number of questions earlier today. You did answer one of them, and I appreciate that in terms of what the statute says, but that statute deals only when the state withdraws from the PIHP contract, I believe. And second, and in this case, the concern is what happens if we go into the risk pool and don't have the resources, whether as an authority or otherwise. And I don't know what the state's going to do, and nobody has a crystal ball, but we'll leave that for another day. But I am concerned about the high cost and whether we need this and who's going to pay it. So for what I asked in my email to you earlier today, and maybe you can address, I'll kind of lump the questions together, is what is our current ISF balance and what other sources do we have available? And in that, the recommendation that came from the task force came on the assumption that the county would cover this cost rather than the CMH board's budget. If that's still in play, Kathy indicated it was still an open question, I think, to me earlier. Maybe you can give me some more information of that. What's the total cost of this contract? I mean, technically, it looks to me like the minimum is $3,000 a month or $36,000 a year. Maximum, if you had this full time, which nobody intends, would be $780,000 a year, not counting expenses and or benefits. Do we have other employees or contracts that are paid at this level? I remember we negotiated your contract and it ain't quite at that level exactly. Okay. So you're setting this up, right? Good, smart move on your behalf. Although I think there are others who may want to argue about setting that up, but that's $375 an hour for information that is probably not germane, in my estimation, when other sources of information that is more important to this particular area, to this county, to the unique nature of this county, is available by looking at the Martha T. Berry and the Macomb County Road Commission experiences, both of which I think we can look internally for. So I'm asking, where are we going to pay for this? How are we going to pay for this? And what do we really expect the full amount to be? The letter of engagement looks like a contract to me, smells like a contract to me, I think is a contract to me, has a lot of boilerplate language that is Raymond's and beneficial to Raymond, not necessarily to us. Who would sign this contract? Would it be the county exec as well as you, which is the normal case in terms of contracts? And who else are we paying this level of dollars to? Because I don't think anybody is being paid that level.
I did respond to those in the email that went to the board. The current ISF balance, the way it's reported to the state, is a little bit under $200,000. We do have an unrestricted fund balance of between 4 and 5 million, on the safe side 4, that's in an account at the county level. So worst case scenario, we had to cash everything out. That's what we have available. There was discussion, and we are going to the Board of Commissioners because they're part of our the authority task force as well, to see what, if any, part they'd be willing to pay towards that. Lynn was working with me to get it into the civic clerk software package here, and with Phil to get it on the agenda for an upcoming BOC meeting. So I don't have the exact amount for that, but we are following up with the Board of Commissioners. The estimated cost of this contract, I have no intention of going over the 1 day per month and limiting it pretty firmly to the 1 8-hour day on site. If something comes up that I'd have to go over and above that, I'd be happy to come back to this body to get that prior approved. But I think, and in discussions with Cindy, our CFO, that we will work to maximize his time on site and limit it to that. As far as other contractors making that hourly amount, no. We do have vendors who are providing services who are getting more than that. But as far as a consultant or an employee or an independent contractor, no. The closest we'd get would be, in the 200s at the psychiatrist level. The copy of the contract is attached. And your other points, Nick, really weren't related to the Raymond situation. They were related to issues if the state has a problem with our contract.
Just as a follow-up, in terms of this contract, it is not contingent upon county funding. So we would be entering into this contract from from agency departmental funds, unless we could negotiate something with the county.
Yeah, it's my hope that we'd have more detail prior to our full board.
And is there any, I don't see the standard language that says if the funding isn't available, it's terminated. So this has not yet gone through the corporate counsel office, or it has?
It has gone through Corp Counsel, and there was a minor change to the fine point in the attachment, but that was the only changes that Corp Counsel recommended.
Well, again, I think, the optics of this is horrendous when we pay psychiatrists $200 an hour, as you indicated, that we're paying a contractor to advise us to do what is uniquely a Macomb County experience, because we're the only charter county in the state. Though actually, the other charter county,
Wayne.
yeah, we're one of only 2 charter counties in the state, and so our situation is completely different. And Detroit Wayne, though it's the other charter county in the state, is dramatically different because its board is composed of half city appointees and half county appointees, so it's hardly something we can compare to. And we have other internal experiences that I think we should look to before expending this. The optics, though, it really disturbed me because we've been cutting everybody else. And then to hire a consultant to do an examination of how things can or should work in our county, I think without the restoration of provider contracts and trying to deal with the cost of direct care workers and trying to deal with the cost of even psychiatrists who were losing right and left because of payment questions, is I think the optics are terrible. I think the policy is very bad, and I think the concept is unnecessary, and so I'll be voting no.
Thank you, Nick. Megan?
For the board members who aren't part of the special task force, will this gentleman be made available at any point to kind of talk to the rest of us board members? Can that be one of the days just about it? Just because I want to understand more about an authority too. I'm still trying to get a hold of how we are here now. So it would be nice if you could just factor that in, maybe take up a quarter of a day or something. Was that the plan, or was it just for the task force?
Initially, it was primarily for the task force. We are looking at other consulting resources to our finance department in general. We met earlier this week with county finance, the auditors from Plant Moran, and we have needs outside of the task force, which would help fill Richard's time. We could definitely ask him about putting together information, or the notes from the task force could inform this body, and if you had additional questions, we could definitely factor that into his time, especially early on in this agreement.
Thank you very much.
Thank you.
Thank you, Kathy?
Thank you, Mr. Chair. I support this. I think we need to get the information that Richard's experience, I think, will help us with. I think Nick also brings up a good point about, there is the transition that the county made in turning Martha T. Berry Hospital over to its own to a different type of operation instead of a county department. The one thing, I was a county commissioner when that transition happened, and the one difference is the county finance department was very familiar with the Martha T. finance at a much greater level than they are with CMH and how it works. In fact, in that meeting that we had and county finance was present, Steve Smeagol, the director, had even said that there's always an issue with reconciling the books at the end of the year. I mean, it's because it's not the same thing. They don't just move the numbers over from one department to the full. You always have to do some other things with it. And then the other, regarding the cost of the consultant, it is a lot of money, but there's not a whole lot of people in Michigan who have the experience of working with the transitions from an authority to the government or the other way around in terms of the full financial piece of it. So I think it's a lot of money, but I think we need to spend that money, and there's already things in place to make sure that the hours here are very wisely spent, trying to get as much done ahead of time to present, instead of him digging for numbers. I believe the intent is for us to give him the numbers, and I think you even did you even asked him some questions ahead of time that we don't have to pay for that time, so that he can get to work analyzing right away, not just gathering data. Is that correct? Okay. Thank you, Mr. Chair.
Thank you, Kathy. Linda?
As a member of the Authority Task Force, I support this request. And what I've seen is that as all the people who sit on it have brought their expertise and their information, we're kind of at an impasse now. And I always saw this as needing some kind of facilitator. First of all, our staff is so stretched, so thin, and that to put this on somebody else's plate, there isn't staff people who can do this. And I am interested in knowing what the contribution from the Board of Commissioners and the county would be. I think that's a logical question. And can't read my other note, so I'll pass for now. But as a member of the committee, I do support this.
Thanks, Linda. Ryan?
I also support this motion, and it's because this is a very tremendous issue, and we don't know really what we're going to do, and I'm interested in what the task force is going to decide. And so in order to make that decision, I want to have all the information presented to us. And I second what Megan had to say, and I would really appreciate having this person available to us to get a full picture and really dig deep in what this means, because it is such an important decision to make when the time comes. And so I would really appreciate if you could have that person do that. And I have worked with experts, UHY, Plant Moran. I know they're expensive. And so we just hope that the expertise is well worth the price. But I will support this motion.
Thank you, Ryan. Linda?
I remember
To finish your first point.
It says public, and it's to Megan's question. At our committee, the public's always invited, and so you would be welcome to come. Our next meeting is, I think, Kathy's the chair, but can I invite them, Kathy? The next meeting is went from 1 to 3 this Thursday. And she'll gavel you, but no, as a member of the public.
Thank you, Linda. Dana?
Thank you. Just a quick question. Did we get a proposal from anybody else or just from Reman?
There was no RFP. We reached out to him to see if he would be willing to assist.
Okay, thank you.
Thank you. Brian?
I honestly can't see the need for this. We've gone through this many times, and it still showed up that we're doing a better job than we would be to the authority. And for the past records for the county, when they have turnovers, it hasn't worked out for the consumers. There's been shortages going on. There's been different issues that are going on. I mean, Martha Tiberi, we had 2 of them that had been walked out by the state attorney general for abuse situations. And I really don't think it was under county control that we would have that issue. I'm going to vote no on this.
Thank you. As a member of the task force, Linda always asks Randy if his board approves everything that he's doing, and he always says yes when he comes forward to us. Our task force unanimously approved this because we have gotten to a point where we can go no further. And on top of that, we also need that expertise at the Board of Commissioners level, because the Board of Commissioners ultimately decides if we become an authority or not. So if we can hire this person to come in and simplify it as much as possible, because it's tough for the Board of Commissioners to wrap their heads around CMH to begin with, let alone an in-depth analysis of authority or what we do now. So I fully support this. And are there any other speakers before we move on? No? All right. Seeing none, we have a motion and support. All in favor signify by saying aye. Aye. All opposed? We have, is that 3? Brian, Nick, and Dana voting no. Motion passes. All right, next is item 5G, residential lease A. I'll take a motion to approve for full board. Motion from Linda, support from Nick. Anybody have questions on this one? Can Tracy stay where she's at? All right. We have a motion and support. All in favor signify by saying aye. Aye. All opposed? Motion passes. Good job. Next is receive and file. We have nothing to receive and file. Item 7, resolutions. We have no resolutions this time. 8 is other agenda items. Linda?
Well, I see Sheila in the audience, not putting you on the spot, but is this your last meet? She's always in the audience. Is this your last board meeting, Sheila?
I'm not sure.
Oh,
So I was offered the position of a director, division director under senior services, so I'm very excited about that. But there's quite a process involved with that, so the Board of Commissioners has to approve it because it's an appointed position. So, yeah, it's, I don't have a date yet, but yes, I'll be
well,
moving
I
on.
didn't want your leaving us to go without any remarks because I have always found you to be such a you cried when we talked about you leaving. So
Right.
you've always been very dedicated. And whenever I talk to you, you always are telling me about something that you're kind of doing quietly behind the scenes without funding. So,
Yes, right,
So we're just going to really miss somebody like you. I am glad to know you're going to the senior department,
Yes.
but very sad for you to leave.
Yes,
community
and
mental health.
it's bittersweet. I'm sad as well. After 30 years of working for CMH, I'm going to miss the people, I'll miss the board members and your dedication, and I appreciate everything that you guys do and the time that you devote. My heart and soul is still with, CMH and the consumers that we serve, but it was an opportunity that I couldn't pass up, so thank you.
Wish you the best.
See, Dave gave me 2 tasks this week. Find $36,000 for Richard and to make sure you stay at CMH. So, all right. Next up is Brian.
I came across on the United Way Michigan website, and it's access to behavioral health care in Michigan, and it's a final report. And I got copies for everybody. I think there's quite interesting into it. I skimmed through it. I haven't really read through it. I just seen it this morning. But there are many charts about different disorders, episodes, substance abuse, opioids, and it's broke down by age groups, gender, and race. And I thought it was something interesting to take a look at. So I got copies for all the board members and some for staff too.
Thank you, Brian.
Thanks, Brian. Kathy.
Thank you, Mr. Chair. I'm not sure if Dave's going to speak some more about our meeting. Are you going to say anything more at this meeting about the meeting we had with the Board of Commissioners in Plant Moran? Not. I'll just give a broader overview. One of the this past week there was a meeting with some commissioners from what committee do they represent? The Finance?
The Finance and Audit Committee.
Finance and Audit Committee from the Board of Commissioners. Plant Moran, who is the audit company hired by the Board of Commissioners. And I think they had 4 of their members there and 1 on the line. So I took that meeting very seriously, that they had 5 people present. There was the director of our own community mental health finance and another employee, along with Dave and Phil and myself were there. And the county director of finance were there. And it was all the main reason for the meeting was a finding in the 2016-17 audit and the 17-18 audit that was the same, that there was an issue that needed to be cleaned up, taken care of, and that has been, in fact, before this meeting already, Dave has put many things into place to make sure that that issue isn't there anymore. But one of the things that hasn't been said, and I'm going to just say it here, is that one of the reasons that this task force are the looking into an authority, just looking into it, doing the investigating and studying it, is because we were told by the Office of the Executive if we didn't do the study, they there's a very good chance, in fact, the words were, we won't sign the PIHP contract for the 2019-20, I believe. They have said that they're going to, we were told they will sign, I think they already did sign it, they had to, right? That had to be signed, but I want the board members to know that we're keeping that, like, we want everything to be done in a way that provides the best service for the people we serve through community mental health. But we, as board members, we have a fiduciary responsibility, as the Board of Commissioners has a fiduciary responsibility, and I know we all take that very seriously by the comments that we make, whether we agree and disagree on issues. I think we all have two things. One is to serve our the people that we serve with the best care we possibly can, and the other is that we also are financially prudent with the tax dollars that we're using, whether the money comes from the federal, state, or local government. So I just wanted to bring that to everyone's attention, and we had this meeting. The very serious things are going on, and part of having this representative from Raymond come in was discussed at this meeting too, and that's being seen as something very positive, as a way to help us financially, making sure that everything stays financially proper. So just wanted to bring that up. Thank you.
Thank you, Kathy. Nick?
Yeah, to Kathy's point, or if through the chair, if I could ask Kathy, we had discussed, and I had heard from the executive as well, that there was questions of whether or not to sign the PIHP, which of course would be ridiculous. I would eliminate 90% of the funding and immediately lay off 150 people in the department and terminate every contract. But I understand that his concern was about our internal financial pieces, which is one of the reasons we put together the work group, and I'm very grateful that we did that. But he had also indicated that there were specific audit exceptions, and while I don't think those need necessarily be made public yet, since the audit report isn't issued, I think, or is it?
Last year's was issued.
Is
I think the other one's been on the agenda. Yeah, the other one, second one has been also.
So can we get a copy of the exceptions that relate to the Department of Community, to the Department of CMH? Because I do think, and I agree with Kathy completely, we have a fiduciary responsibility. If there are problems with the finances, again, bringing in an outside consultant, I personally think is an unnecessary, expensive, extraordinary measure, but it is something that we have to talk with our financial people. And there have been folks who have defended them, but if they aren't doing the job, then we need to know why, because that's their responsibility. And if there are audit exceptions, I'd like to know what those audit exceptions are and what the staff intends to do to address them, or what actions we need to address them. That's a very serious concern. I don't know if they were substantial exceptions or material exceptions. I'm used to reading audits. I've done it for 20 years at the state level, and I've seen audits that said, well, there's a little problem here, and then there were material breaches of policy that are much more serious. And if there are such things, one of the concerns was that we didn't close our books in a timely fashion. Traditionally, we've dealt with that by board policy, by changing our billing system to make sure that we tell people, if you don't bill us in a timely fashion, we're just going to pay you, so that we can close our books early. And there may be other policy changes, but I think it's the responsibility of the executive director to share with us any audit exceptions that have been presented to the county that relate to this department and agency, and that we take action to resolve them. If we're going to pay a consultant, obviously I might as well take advantage of it, but I think there's the expertise here to be able to address those things. But I certainly would like to see what those audit exceptions were and what action has or hasn't been taken. I appreciate the fact that the executive director and the chair have been meeting with the county exec and with appropriate people on the county board of commissioners. That's a good thing to do. That's the right thing to do. But I think the full board needs to be brought into those, not necessarily those discussions, but as Kathy attempted to do, keep us apprised of the results of those discussions, and we need to see that in writing.
Kathy?
Yeah, we'll get that, but the second year was very similar to the first year. I don't want to bring all of this up at this meeting. I just wanted to really give an overview so people knew what's going on and why. Yeah. There's something else you said I was going to address the part that, but that's not the only reason for hiring this consultant though. But that became a part of it that made it that the Board of Commissioners actually made it. I think they were more interested in helping or in assisting with perhaps paying because of that too. Looking at trying to get, like you kind of mentioned, you get more for your money when they're working on a couple different issues. So, thank you.
Anyone else before I turn it over to Dave? All right.
Good evening. Just so I don't lose my place, I will send out the audit reports. We will review them at the board study session on the financials. There is a response due back to Plant Moran, and we will share that with the full board as well. That study session on the financials is Tuesday, August the 27th, bright and early, 7:30 a.m. at our administration offices. So please mark your calendars. Brian, thank you for this very much. I do have it open on my computer and I was reading it. We do have a current 90-day rock project specific to access, so this report was very, very timely. We are looking at seeing what parts we can incorporate or do our compare and contrast to. Debbie Stabenow, I got an e-vote which I will be sharing with everybody electronically, so there's no need for notes. She's having taking time to touch base on what she's working on at the Senate: healthcare, expand mental health services, lower prescription drug prices. So she's having 4 like town hall meetings, one in Southfield, one in Flint, one in Grand Rapids, and one in East Lansing, and I will share those details. I was also invited during Nick's legislative committee. I will be over at the Judson Center, and Senator Stabenow and Peters will both be present at that event. And I'll share updates after. On the funding side, there's discussions going on that the state will issue supplemental funding to the system, to the PHP system for this fiscal year. It's $49.8 million statewide. We're not sure, it's not definitive yet that will come, but it's being talked about a lot. And the exact methodology for dispersing those funds is not certain right now. So I'll provide updates on that. Sheila, you were on my bullet points to discuss as well. Yeah, big shoes that she's leaving behind for us. But she will be close, still in Macomb County. We talked about being on the Human Service Coordinating Body together, and actually sent you a integrated healthcare project for seniors with mental health issues. So we'll try to keep her close. And thank you on the board. You guys passed the approval to reclassify Sheila and actually give her the nice promotion. Just saying. On to the staff, I don't know if I announced to this group, I did report it to the state. Laura Manza is in the audience, and Laura's our current interim compliance director. That's one of the few positions that's mandated in our contract. So when our former director left, Laura was kind enough to readily step into that role. I was notified today that the applications have been closed and they're sitting on my computer for review and follow-up. So we'll start the second phase of that very shortly. Adam and I had a meeting first thing Monday morning with a Medicaid health plan who is interested in doing some integrated healthcare work with us. The meeting went really well, and we will be following up on those activities. If you recall, some of the original restructuring in my 100-day report was to have the position of chief clinical officer in place, and then to organize our integrated healthcare activities under that position, who would then report to the chief medical officer. Randy's opioid health home, we're going to do a dotted line to our other integrated healthcare activities. The work that we will do following up with the Medicaid health plan, along with our My Health Link, the current Medicaid health plan project, which is the performance-based factors, that's the clawback where we're able to earn $1.4 million that they withhold from us during the year. So that's really important. We shore that area up, and all of our other integrated healthcare activities. So we'll continue to give updates on that. Richard available. And I'll leave it at that, and I'll give additional updates at the full board meeting later this month. Thank you.
Thanks, Dave. And I just wanted to end on a really short story. I'm a huge hockey fan. Many of you know that. And the NHL awards were a couple months ago, and one of the players there was receiving an award. He was 27 years old. He'd played in the league for 9 years. He was a mediocre goalie, usually a backup goalie, and he ended up taking the New York Islanders into the playoffs. Come to find out, the season before that, he was diagnosed with issues of substance abuse, and he was diagnosed with bipolar 1 with manic phases. And he didn't know this about himself. He understood his drinking problem, but didn't know the second part of it. He ended up playing the best season of his life and was rewarded the Bill Masterton Memorial Trophy, which is awarded to the player best exemplifies the qualities of perseverance, sportsmanship, and dedication to hockey. And while I was reading an article about his story, the part that got me was a quote from him directly, and he said, "I'm mentally ill, but that doesn't mean mentally weak." And that stuck with me, and I just wanted to share that real quick with this board and the staff, because I think that's why we're all here. We're here to help folks like him and basically rise up and defeat your illness, defeat whatever your demons are, and become a better person. So I just wanted to share that story real quick. Any other board members with anything else? All right, seeing none, we'll go to the hearing of the public. Anybody from the public wishing to speak? Going once, going twice. If anybody wants to see Tony tomorrow at the Board of Commissioners, it's at 3 o'clock here. With that, we will adjourn.
You said day early.
Yeah. Thank you all.